We'll just introduce ourselves. This is a shared presentation, and it's from Broadmoor to Roux-en-Y, a shared journey. The Roux-en-Y isn't somewhere in France. It's a type of bariatric surgery. I'm aware that Rampton has more experience of this than we have, and we have been helped actually by talking to people at Rampton, but we thought it would be useful to talk about our experience. I'm a psychiatrist at Broadmoor, and I work on an assertive rehabilitation ward within the Personality Disorder Directorate.
And I'm Linda. I'm one of two dietitians based in the Physical Healthcare Centre at Broadmoor. One of our aims as a team is very much to offer equal access to our patients, both for healthcare and healthcare outcomes, as those people who haven't been diagnosed with a severe mental illness. And it was really with that in mind that we looked into the option of bariatric surgery for some of our more obese patients.
Okay, so exploring the option. The travellers, that's the patient and the clinical teams, and it was a very multidisciplinary piece of work. The context, obviously, the procedure and the setting, and then the risks. The risks to the individual and risks to the organisation. I mean, we had concerns if we went down this path, would the patient then be suing us for having surgery which didn't work out? Or if we didn't go down that path, would there be issues? So there was a lot of deliberation in terms of proceeding. The directions, the guidelines that we used, and the milestones on the way. So that's the sort of the background. All right, so just briefly about the patient. Anonymised, but in late 30s, a male, been in Broadmoor since 2001. He's on a hybrid order. He has the potential to go back to prison. So he's got a foot in a prison camp, but also in a hospital. History of serious offending and diagnosed with a complex personality disorder. High psychopathy scores and high functioning. The sort of person that most people would know about within the hospital. This person used to be a prolific complainer, and then he turned a corner. He had some therapy and became more reflective, and is now prolifically or enjoys therapy. So he has a lot of therapy. But he was someone who complained a lot. So I think that also entered into our thinking. I mean, were we going to get it right or not? He was compliant with his medication, he's compliant with his therapies, and he's on a minimal amount of medication. So his obesity was not linked to medication. This is a person with a strong presence, who emotionally can get to people, who causes strong reactions in people. Some people say, of course he shouldn't have surgery. This is ridiculous, he should just diet like everyone else. Others will say, well, perhaps he should. You'd have staff who might be obese and might be wanting surgery, thinking, where does this fit in with when this person is being recommended for it? So this is someone who aroused a lot of emotions in staff. You know, we could say that it was a lack of integration and splitting, and that was projected into the team, and we talked about it in reflective practice, but we could talk and talk about it, and you get a group of people together, and people had different views. So how were we going to make the decision? Linda.
As far as our patient's physical health goes, he had a body mass index of 48, so he was classified as being seriously obese. He'd also been diagnosed with a number of morbidities associated with obesity, including diabetes, dyslipidemia, fatty liver disease, and joint pain. He'd got a cardiovascular disease risk score of a 17, and a score more common for someone of this gender and age would be 2%, so his risk was quite high. This isn't or wasn't a lazy patient. He works almost full-time within the hospital. He's been described by his supervisor at work as an exemplary worker. He spends much of his day on his feet and spends his time between the shop, the cafe, and the hairdressers. And often on the ward, he can be found cleaning and tidying the kitchen. As far as exercise goes, he really used to enjoy exercise, particularly football and working out in the gym. But as his weight went up, he found this increasingly more difficult to do and became very self-conscious about doing so. He was and is, in fact, very knowledgeable about diet. He did actually win the healthy eating quiz at our wellness day in the summer. Unfortunately, although he had this knowledge, the diet that he chose to follow was of very poor quality. He did have a very erratic eating pattern and often chose to skip meals. Unfortunately, the result of this is that in the evenings, he was often found on his own in his room, mindlessly eating large quantities of refined carbohydrates such as bread and cereals.
Yeah, okay. In terms of his background, there's a family history of obesity. As with so many of our patients, a history of abuse. Food was used for comfort. Fat as a teenager, called a fatty. He has spoken about eating from a sense of loneliness to fill a hole of emptiness. And of course, he could binge and could never really fill that hole until he then became so full he might vomit. But despite all this, like in piece of rock, he never wavered in his desire to lose weight. So despite the ups and downs, trials and tribulations, he was always wanting to lose weight, which some people said that was a projection. He was projecting all his difficulties onto his weight and obesity when he should be thinking of other issues. And he consistently tried and failed various means to stabilise and lose weight.
And this rather crude graph, which has come straight from our health centre system, actually is a record of a 7-year history of failure, really, and failed dieting. You can see a typical pattern there of weight cycling. Now, this patient was obese when he was admitted to the hospital, and you'll notice that around 2007, 2008, his weight did reduce significantly down to 98 kilograms. Unfortunately, the way the patient did this was he starved himself and carried out excessive amounts of exercise, which was completely and utterly unsustainable. And following that, you'll notice his weight rising quite quickly up to a maximum of 165 kilograms early in 2011. And there's a history of tried and failed diets. And something I've learned from the exercise with this patient is actually to recognise this pattern of weight cycling much more early so that you can take action earlier than perhaps for this patient. You can see from the table that our patient was offered a number of dietary interventions to try and help him. We tried all of the diets recommended in the NICE guidelines, CG43, and a few more besides. He tried some of the options twice. As far as exercise goes, he was offered a number of opportunities by our qualified sports and leisure staff, and there's also a Wii Fit equipment available on all of the wards for all of the patients to use. We also tried behavioural therapy. DBT had been used successfully with this patient in the past, particularly in regard to his prolific complaining. So we tried it in regard to food and diet as well. He was also given motivational interviewing by skilled clinical staff, and we also tried mindful eating. Unfortunately, all to no avail, but we did try our very best to help him.
Okay, talking about the prevailing culture, I mean, this had been touched on earlier, so, but you know, the scandal of premature mortality in those with mental illness, that's Thornycroft in 2011. I'm aware that when people first talked about bariatric surgery, I think some people thought, well, morally, is this the right thing? But it seems becoming more of age. You know, there are articles in BMJ and advances in psychiatric treatment, hot off the press, psychobariatrics, that came through last week, you know, so it's as if it's more around, it can be more spoken about, and more people are actually having surgery. No?
Try escape.
Escape, I think, yeah.
As far as the NICE guidelines go, with a body mass index of 48 and associated comorbidities and a 7-year history of failure, our patient did fit the NICE criteria for bariatric surgery. Now, the aim of the NICE guidelines was to stem the rising prevalence of obesity and the diseases associated with it. The guidelines were produced in 2006, and it's widely acknowledged that they failed to achieve this. There was a review of the guidelines carried out in 2011, and the conclusion that the reviewers came to that there wasn't enough evidence out there to make any changes to clinical practice, and therefore they made a decision not to update their guidelines. However, they did acknowledge that there was an increase in the number of bariatric operations that were carried out, and there was certainly evidence of positive weight loss outcomes. 4 of the studies looked at confirmed that bariatric surgery could be a cost-effective way to manage weight, something that's quite important to the NHS at the moment.
Okay, talking about my position, because this person's detained in a high secure hospital, I was required to approve a referral for potential surgical intervention. And there weren't really any guidelines for this. We hadn't done this before at Broadmoor. And I had to think about, did this person have the capacity to understand the pre- and post-operative risks and consequences? And as I mentioned earlier, what were the risks to the individual and organisation should we go down this path? People spoke of the possibility of another maladaptive behaviour arising. People actually said, is this the ultimate form of self-harm, that this person will allow himself to be operated on? And there was tremendous conflict amongst staff. Everyone had a view, and there was a lot of disagreement.
Now we're just going to talk about some of the milestones that we came across on our journey. The journey started back in January 2011 when our patient admitted that his eating was way out of control, and he expressed a wish for bariatric surgery. Later on in January, our GP discussed this with our visiting general surgeon, and he gave us a rough action plan to follow. For me, the journey began in earnest in May 2011 at the Secure Physical Health meeting, where we share practice, and it was the generous sharing of practice from the Rampton Dietician that really made me feel more confident that this was an option for our patients. So it just shows the value of those meetings that we have. The following month, Dr. Edwards assessed our patient as having the capacity to consent to the procedure, and also provided written support to accompany the application that Dr. Cohen put into the PCT.
Okay, the PCT granted funding. Then there was negotiation with commissioners and service providers, and a provider of choice was allocated. And then in September 2011, we started having regular meetings. This was very MDT, so it was the healthcare centre, it was ward staff, anyone involved with the patient almost, to discuss the way forward. And in March 2012, the person was assessed by the appointed trust. 6 staff accompanied that person to the assessment. So you need a certain number of escorts. So you've got, all the issues involved in that. But we also, I sent the junior doctor, I said, take notes. I want to know exactly what will happen, et cetera, et cetera. So we really wanted to know what this would entail.
I was one of the team that escorted the patient to the hospital, and at the hospital he was assessed by a specialist clinical team, including the anaesthetist, the surgeon, the psychologist, the dietitian, and 2 specialist bariatric nurses. And that was a good opportunity to learn about some of the benefits and risks of the bariatric surgery. And it was the Roux-en-Y gastric bypass procedure that was recommended for our patient. Initially, we'd been hoping for something not quite so permanent. We'd considered a gastric balloon, but there really isn't very much evidence for positive outcomes for the balloon. Our second choice would have been the gastric band, but we were assured by this very experienced team that the Roux-en-Y was the best option for this patient in this setting, and we took their advice on this. There are around about 1 in 200 patients die from this procedure, but they do tend to be the older patients with, and often with, poorly controlled diabetes. We were told to expect a length of stay of about 2 days, and they also mentioned some of the complications. About 20% of patients suffer from complications, some of what you might expect from surgery anyway. In addition to that, about 85% of gastric bypass patients experience something called dumping syndrome. And also, almost all patients that undergo this type of surgery experience some regain of weight at 18 months to 2 years. So that's something that we've yet to discover as far as our patient goes.
Okay, in terms of assisting us in how we would proceed, because there was a lot of conflict amongst staff, I thought it was important to inform line managers, but also have the issue peer reviewed. So this was done in 2 settings. So the issue was presented at Broadmoor in an academic round, and then it was also presented at Ealing, where we had a much more mixed audience. So we had general psychiatric colleagues there as well. And we got 2 different views. The view from Broadmoor that this was the ultimate form of self-harm, right? That we shouldn't be going down this path because this particular person had lost weight before, albeit sort of living on a couple of biscuits and exercising. And they thought that, really he just needed to start, dieting properly again. But at Ealing, they said it was an appropriate intervention. And I suppose the whole issue, can we be objective? Because everyone's got views about food. I mean, there are staff who've had the operation, would you believe? And somehow or other he got to know that there were staff who had had an operation, not staff he worked with. There were staff who were obese who might have wanted an operation, and everyone had a view about this. So we started these regular minuted meetings to inform the decision process, and we initially said you need to have decided by, say, the end of May, then it was delayed until the end of June or whatever, because once the surgeons say, let's go ahead, operate, they want the person in days, literally. Twice, that person, he requested more time to decide. There was the issue about could he have specific psychological input. Now, this is someone who's already attending groups, having one-to-one therapies, who is a bit of a therapy junkie, and who should provide that? And psychologists were reluctant to. We don't have experience of this. But eventually we did get someone, a very senior psychologist, and it was agreed that he would have 6 time-limited sessions to tide him just prior and after to the surgery. And all along we told him the decision to proceed was contingent on his compliance, that he would see the dietitian, that he would do this, he would do that, because I think it's quite slippery at times, and we'd have an issue that, who was in control of this, really. In July, he actually started on the liquid diet, which you have prior to the operation to help shrink the liver, and he was perfectly compliant in that time. He was more compliant then than he had ever been, and the psychological work had begun. 6 sessions.
The surgery was performed in August of this year. And the patient was discharged back to Broadmoor within 72 hours. He was discharged quite late on a Friday afternoon, which did necessitate poor Dr. Edwards having to stay quite late into the evening to ensure that everything was properly in place. Whilst the patient was in hospital, I carried out a series of training sessions, some on the ward and some in the catering department. The ward were very keen to learn about dumping syndrome, which probably sounds a bit more complicated than it really is. I also had to give training as far as the modified texture diet goes, and lots of housekeeping issues around portion sizes and meal delivery and timing. The psychological work was completed, and as a result, our patient appears a lot more emotionally contained about food than he was prior to this input. And over the course of 12 weeks, he did follow a very transitional diet, which started off as a liquid diet and then gradually made the transition to puree and soft. And last week, we started him on more solid textures of food. There are many ongoing issues, not least of these is taking medication, which is very difficult and time-consuming, although we did make every effort to adjust his medication to make it easier for him. Meal provision is an ongoing issue and has been very time-consuming trying to resolve those problems. And undoubtedly there has been effect on the nursing staff, the patient's peers, and not least of all on the patient himself, both physically and emotionally.
Right, I got some feedback hot off the press. He said the process was good, the surgeon was brilliant, the guy made eye contact. So he really appreciated that. And he liked the fact that there was a full MDT assessment by the surgical team, as well as all the MDT work going on back at Broadmoor. He thought that the psychiatric nurses, when he returned to Broadmoor, were not always aware enough. We do have people who are dual trained, but we seem to have less of those currently. He thinks he should have gone back to a physical healthcare bed, not to the parent ward. And we did discuss this, and he wanted to go back to the parent ward. And we don't actually have a physical healthcare ward, although we have a designated physical healthcare bed. But he's now saying that it would have been better if he could have had some convalescence in a different environment than the ward. He said that the post-operative pain was bad. We talked a bit about the physical changes noted, and he actually spontaneously said that he feels more open with his emotions. He finds it easier to talk. So is this that he's got less of a physical defense, he's got less of a barrier of lots of fat, and he's less emotionally defended? I don't know, but that's his feedback.
Patient's also delighted to report that as a result of this process, he's lost 40 kilograms in weight over the course of the year. 10 kilograms of this was as a result of the pre-op diet and the pre-op work that he was given by the specialist team, and 30 kilograms of that is post-op. He's slightly ahead of schedule, but not too much. He says and reports, as you might expect, that he doesn't feel particularly hungry, but he does crave being able to bite and chew food. He says he's very mindful of food, but he doesn't particularly savour it when he does eat it. A habit that he's getting into that I'm trying to work with him to get him out of it again, he's become very obsessive about counting calories, even though he's having a very low amount of calories at the moment as a result of the surgery. Swallowing tablets is difficult and does remain a problem. One of the side effects that he did experience was an awful lot of very painful winds, particularly in the first 2 weeks after the surgery. He's experienced dumping syndrome twice. On both occasions it was after drinking a cup of tea far too quickly, and the tea, as far as I'm aware, didn't contain any sugar. And he's also recovered sufficiently enough and lost enough weight now to start to enjoy his exercise again, which is another positive outcome from the process.
Okay, so this is the final slide, and this is really joint. This is what we've learned together. It's very much a shared journey. So I think you can...
So we started with an obese patient diagnosed with comorbidities who was at risk of early mortality, and he fitted the NICE criteria for bariatric surgery.
He had the capacity to make the decision to seek out surgery, and there were serial assessments in terms of assessing his capacity about whether he should go down that path.
The decision was supported by the senior clinicians and also the clinical team at Broadmoor and West London Mental Health Trust.
He underwent Roux-en-Y with significant ongoing weight loss.
And as a result of this, we've got now 3 other patients who meet the criteria who've also expressed an interest in bariatric surgery.
And I guess there's something about our changing perspectives. I definitely feel far more confident about what to do, because I did feel very anxious in the early days. And I think what has sustained me, us, is we did such joint working. You know, we just met regularly. You know, it was once a week, once a fortnight, minuted meetings, particularly with the nature of this patient, I think, who could have tied us all up in knots, I think. Is that fair to say?
Yeah, I think so.
I think that's it.
Yeah, it was multidisciplinary working at its best. It's probably the biggest and strongest team that I've worked with.
Okay, thank you very much.